Good morning, everybody, dear colleagues, dear friends. Welcome to the morning session. I hope you had a lovely night yesterday and you are full of energy for the rest of our day. So the topic for this session in the morning is going to be timing of implant placement. When immediate, when early, when delayed implant placement. And for me, it is a true honor to share this stage with a friend, a reference in this area, Professor Jan Cosyn.
Good morning to you all. Good morning, Helena. I know you told me that you didn't get a lot of sleep.
No, I was in the yoga class at 7 a.m.
But
today.
as always, you look stunning, so the pleasure is all mine for doing this together with you. Welcome, everyone. So we have, I think, an exciting session ahead. And we have prepared a case for you, just as a warm-up, with a poll question. Exactly. Could I have the presentation for that, please? So we want to get you involved a little bit into the theme. And we have here selected a female patient, 25 years old. She's a non-smoker, and she had a trauma 15 years earlier. There are no deep pockets. She's periodontally healthy. And you see the corresponding CBCT slice on the right side. The question is very simple. What can we do, or what would you propose to do in this specific case? Option A is immediate placement, B is early placement, C is ridge preservation, and D is the bone augmentation. In order to select the appropriate answer, you go to the EAO app, and you have there the polls you can select. And then the question will pop up. So I give you a minute or so to think about it, to go to the EAO app, to go to the polls and select the appropriate answer. So option number A would be immediate placement, regardless of the fact whether you would combine it with an immediate restoration procedure. So it's mainly the surgical part here. Then B, early placement, meaning we wait for 4 to 8 weeks before placing the implant, and usually this is combined with a contour augmentation procedure. And here are then, option 3 is alveolar ridge preservation and late implant placement. And then we wait for about 5 months before placing the implant. And if you think that this is really a too complex case that needs bone augmentation in a staged procedure, then you would select option 4, bone augmentation, and you opt for late implant placement. Okay.
So I think we can see the results.
Okay, we have a small majority opting for 3, alveolar ridge preservation and late placement, and to some degree comparable with bone augmentation and late placement. We have now the lectures, and we will see about it, what I did exactly in the end.
Very interesting results. Actually, I was expecting another things, but quite interesting. So we have now our speakers, and I would like to introduce our first speaker. And our first speaker doesn't need any introduction. Professor Mariano Sanz is a world-known expert. He is a professor at Complutense University. He is also a professor at Oslo University. He has been acknowledged by several universities worldwide. He has published more than 250 articles, published more than 50 chapters in books. And yesterday, it was a very special night. Why it was a very special night? Because Professor Mariano Sanz received the honorary membership from the EAO with the gold medal. So I think he deserves a really round of applause. So,
thank you.
Mariano, thank you so much.
Good luck.
Thank you very much, and it's a real honor and pleasure to be here in front of this outstanding audience in this outstanding place. So I am here to, in a way, discuss about the option of immediate implant. And of course, the background is why do we want to do all these different surgical interventions? And the background is very simple. We want to avoid the dimensional changes that occur after tooth extraction that have been fully reviewed in the literature, and we understand that the end result is a major contraction in both bucolingual and apicocoronal dimension of the resulting ridge, which would alter our ability to place implants in the ideal prosthetically driven position. And therefore, we have been discussing for basically 2 decades what is the evidence-based decision-making when we need to do an extraction and decide on which is the best surgical protocol. And here you have a consensus report from the EFP that first authored Mauricio Tonetti, that we discussed these possibilities, and then we came up with this basically framework. And you have there on your left, basically, what can you do at tooth extraction? Basically 2 possibilities: immediate implant, alveolar ridge preservation, and then after extraction, the early, the intermediate, and the late implant placement. Those are the 5 possibilities. Here we are going to discuss possibility 1, that I will support, possibility 2, ridge preservation, and then the type 2, which is the possibility number 3. So let's discuss about immediate implant placement. And basically, through these 15 minutes, I will try to answer some of these questions, because we may say that immediate implant placement is the ideal surgical protocol because the treatment time is reduced, the amount of surgery is also reduced, width and height of the alveolar bone are preserved, I can attain ideal implant location, and the aesthetics are improved. And the question is it all this true? Do I have evidence? And of course, some is obvious, mainly about the time that is reduced, but is it obvious that the width and the height of the alveolar bone is preserved? And of course, if you look at that picture, you may say probably it's obvious that the dimension is not preserved. So this is something that we need to take into account. And our group has been focused on identifying exactly what are these dimensional changes. And basically 3 decades or 2 decades back, we did this study where in an experimental animal study, we compared 4 different implant systems. And we compared the outcome exactly with the adjacent socket that was allowed to heal undisturbed. And you see here one example, the immediate implant placement and the adjacent socket that was allowed to heal undisturbed. And when we look at the figures, we see that the dimensional changes that occurred were always higher in the implant site with the adjacent socket. So which means that clearly placing an implant in the socket does not prevent these alveolar changes. And then of course, and I'm going to try to do a sort of historical review of what we have learned in terms of evidence-based in this surgical protocol. We did a series of studies. This was a team that we formed at that time with Jan Linde and Klaus Lang. And we basically wanted to know exactly what were the changes that occur when we place an immediate implant in a fresh extraction socket without anything else, just placing an immediate implant. And then we measured the bucolingual dimensional changes. We measured the changes that occurred in the gap between the implant and the bone surface. And we also measured the vertical bone changes. And what we saw is that, as you can see, in the upper row, you see enormous changes, both in horizontal and vertical. In the lower row, you see minimal changes. So there is quite a lot of heterogeneity in how a socket will respond when we place an immediate implant. Of course, if we take only the mean dimensional changes, the mean results, then you have an average idea of what happens. Basically, most of the gap is filled with new bone. We have about 1/3 of the bucolingual dimension that is reduced, and we lose about 1 millimeter. But clearly, there are many differences. So when we compared what happens with those sites that have a thin versus a thick buccal bone plate, we saw clearly differences. And as you can see, in terms of horizontal crest reduction, double when the buccal bone is thin, and the same in terms of the vertical bone dimensions. And what we did is, since we gathered more than 100 implant sites that we followed and measured directly, we did a multi-level, multivariate analysis, and we tried to identify which were the critical factors in the different dimensions. And you see, this is what I would call the worst case scenario, which is when I have a very thin buccal bone and I place my implant in close vicinity to the buccal bone plate. Here there is no gap to fill, but since this is very close to the buccal bone plate, I'm going to lose most of the buccal bone plate, both horizontal and vertically. And if I do exactly in the same site with a very thin buccal bone plate, but I place my implant palatal, allowing a gap between the implant and the bone, of course I'm going to get important dimensional changes. Of course I'm going to lose most of the buccal bone dimension, but I will lose way less vertical bone dimension. And when I look at what I call the best case scenarios, that is a situation that I have a thick buccal bone, but at the same time I discern whether I place the implant in close vicinity to the buccal bone or palatally when I place the implant at, sorry about that, I place the implant at a distance from the buccal bone. And then what I see is that those changes do not occur and I don't lose bone in the buccal bone. So with this information we gathered, we began to develop a well set up protocol of how we had to place our implants, and we need space between the implant and the bone. Probably the bone doesn't like to be very close to titanium. And you can see some cases that we have quite extensive gaps, and 5 months later we see that the whole gap is filled with bone, and we have lost, in this case, very little bone, both in the horizontal and vertical dimensions, because it's the worst case scenario, thick buccal bone, implant at a distance from the buccal bone. And you see here the 5-year post-op image with everything maintained. So even in situations that I have a huge amount of gap, here the gap was about 5 millimeters, and we allowed to heal it undisturbed. And what happened? The gap was filled with bone. And then you see this is the 5-year post. So then we asked ourselves, do we need to graft? Because as you saw, in the best case scenarios, we had a full graft filled with bone. And then we designed a randomized clinical trial together with, again, with Jan Linde to see exactly how we could randomize these cases to allow to compare grafted and non-grafted sites and measure the dimensional changes, mostly in the horizontal dimension, so we could see the added value of grafting. And what we saw is really when we put all the cases together, all the sites together, we see a very small but still significant difference between the grafted and the non-grafted sites. The difference was 29% reduction in the grafted sites, 38% reduction in the non-grafted sites. However, and this is very important, when we selected those sites that were 1 millimeter or less in buccal bone thickness, then we saw a huge difference. And you see the difference is between 15% and 48%. So then, of course, the answer is very clear. Do we need to graft? Well, we need to understand and be able to diagnose which site we are working, and then graft, of course, in every site that we have thin buccal bone plates. And clearly, probably the group that has worked more extensively in trying to answer some of these questions is the group of our chairman, Jan Cosyn. He's done beautiful work, and this is one of the systematic reviews that they did, and basically was trying to answer this question. What is the difference between grafting the gap or non-grafting the gap? And you see there are not too many studies, basically 4 studies. but still, they all go in the same direction. There is a significant added value with grafting, and therefore, this is something that we need to take into account whenever we place an immediate implant. And then the critical question. You can see that we can compensate the dimensional changes somehow by grafting the gap and by placing the implant in the appropriate position far away from the bone. And then the question, is the aesthetics improved with immediate implants? And I bring back probably the most important randomized clinical trial published comparing immediate versus delayed implant placement. And this is a study that was coordinated by Maurizio Tonetti, and as you can see, with a sample of 134 patients. Not easy to have clinical trials of this amount of people. So they followed these patients 1 year later, and they compared many different variables between immediate and delayed. And what they saw is that the significant difference was the aesthetic outcomes. And you can see here the results of the pink and white aesthetic scores, and you see the mean in the total WES and the total PES, and you see very clearly that the delayed implant had higher scores, significantly higher scores than the immediate implant. And therefore, this clinical trial stated that immediate implant in the anterior maxilla could be an aesthetic risk, and therefore we needed to be cautious when indicating this procedure. And then, of course, let me share with you one of these cases. We place the implant in the ideal position, we graft, we do everything flapless, we place the provisional restoration, then we wait for the tissue to heal, we do the individual customized abutment, and look at the result. Not a very good aesthetic result. So what have we failed? And basically what we have failed is that we were not able to take care of the soft tissues. And this was clearly discussed and demonstrated evidence-based by Jan Cosyn's group, where they basically asked the questions, do we need to add a connective tissue graft? What is the added value? And clearly, the added value was favoring the placing of a graft in the anterior maxilla, basically for the maintenance of the stability of the mucosal margin, which was the aesthetic problem that Maurizio Tonetti identified. So as you can see, the vertical mid-facial soft tissue change was more favorable whenever we place a connective tissue graft. And basically what we have been investigating in our group is the possibility whether instead of placing a connective tissue graft, we place a soft tissue substitute. And this is a paper first authored by Ignacio Sanz Martín that will talk immediately after me. So the idea is basically the same, is instead of placing a connective tissue graft, to place a collagen matrix that we're able to maintain the stability of that mucosal margin, and at the same time, place the implant in the appropriate position and graft the gap between the implant and the buccal surface. And of course, we had lots of measurements, and we could ascertain that indeed we were able to maintain the position of that margin. And this is just one of these cases where we graft the gap, we place the collagen matrix, and then we place the provisional restoration, and this is the final outcome, which is a good aesthetic outcome in terms of maintaining that position of the mucosal margin. So then, if we use all these protocols, irrespective whether we use an autogenous connective tissue graft or a collagen matrix, the question is the aesthetics improved? And then I come back to my chairman, Jan Cosyn, who did this beautiful systematic review, asking what is the effectiveness of immediate implant placement for single tooth replacement whenever we compare with delayed, but using all these protocols that I have alluded, including the connective tissue grafting and the immediate restoration. And you see in terms of papilla and PES scores that the aesthetics is the same, including even better in terms of papilla maintenance with the use of immediate implants. So you see the question related to aesthetics can also be overcome if we do the proper surgical protocol. So let me basically wrap up by saying that when we do the choice of immediate implants, it's not only immediate implants. It's a very thorough diagnosis of the site dimensions. It's a very important indication of the best implant position, and today we need to do guided surgery to assure that we place the implant in the ideal position. It's very important to have a gap. The bigger the gap, the better, but it's critical to graft the gap if I have thin buccal bone. And it's very important to compensate with either soft tissue substitutes or autologous soft tissue grafting together with the provisional restoration. And then we will get the results that we really want. So let me finish by stating that if I have to ask these questions, and if I have to choose this particular surgical protocol, indeed I will choose immediate implant placement because the treatment is reduced, because the amount of surgery is reduced, because I can maintain most of the width and height of the alveolar bone if I know exactly in which circumstances I need to graft, and always allowing for an ideal implant position. And this is why I fully recommend that all these cases should be done guided, because it is critical, this situation, and it's not easy because since I have to drill in the palatal wall of the extraction socket, the stability of that drilling must be assured by the appropriate guidance during the surgery. And finally, aesthetics is improved. Indeed, it is improved, but I have to combine the whole protocol, flapless, ideal implant position, grafting of the site, compensation of the connective tissue, and the provisional restoration in place. So it's not just the immediate implant, it's the whole protocol that needs to be taken care for making this important decision. And of course, what I try to do is to provide you with a little bit of a historical trip of many of the studies that groups like Jan Cosyn's group and also our group have done throughout the last 2 decades. And of course, I need to render my attribute to the people that have participated in my group, which are the ones who have done most of these field trials and animal studies that led us the knowledge that we have today. Thank you very much.
Dear Mariano, thank you so much for an amazing lecture. I couldn't agree more on many things that you have said, and the structure that you used for this lecture is really perfect. Thank you for your contribution.
Thank you.
I have the honor to announce to you Anina Zürcher. Dr. Anina Zürcher, she comes from the University of Zurich, and she graduated as a dentist in 2014 in Bern. She continued there for a PhD, which she completed successfully in 2018. And then she went to Zurich for a specialization in reconstructive dentistry at the esteemed institution of Ronnie Jung and Daniel Thoma. Anina, you come from Switzerland, so I would say you are perfectly placed to talk about early implant placement. Please feel at ease and come to the floor. Good luck.
Thank you very much. Thank you very much for the kind introduction. Dear audience, also from my side, a warm welcome to the session. And we already heard a lot about immediate implant placement and the importance of decision making when it comes to find the right timing for our implant. And I must say, I will continue with early implant placement, and my heart goes boom. Not just because I stand here and I'm a bit nervous, it's such a huge audience. No, because I also remember about a story in November 2023. I had to give a lecture also about early implant placement, and that was in front of a small group with colleagues. But you know, there was also Frank Schwarz, and it made me a bit more nervous knowing that. And suddenly he turned to me and asked the question, as I asked today, why early implant placement? And I wanted to be very bold, very strong, to give a very good answer why you would do early, but I couldn't. I mean, I had not really a good idea. So standing here again, answering that question, I try again. I can give you at least 4 reasons. There might be more reasons, but 4 I have for when early implant placement. One reason is management of hard and soft tissue. That is one of the first things we have to look at when we have hard or soft tissue defects. And sometimes we cannot solve that together with the implant. Another reason, second, maybe patient wants to fasten the treatment, but at the same time, immediate implant is not possible. So that could be a solution to give to our patients. Or third, you might even get a referral and the tooth is already extracted and no socket preservation was done. Also there, I see an indication. Or fourth reason, why and when we would do early implant placement, and that's just simply us, we as a clinician. And if we have that choice in that clinical situation, we might even prefer early implant placement. So if we prefer that timing protocol, it just brings me to another question. How often is even early implant placement possible? And for that, we have to go into Professor Jan Cosyn's prior practice. So what he did with his group, he did a really nice study retrospectively about timing, about the feasibility. And what they did do is they were looking retrospectively to 100 cases, 100 patients. And then they were looking when and how often a certain timing, immediate, early, or delayed, was feasible. And do you know what they were seeing? Well, early implant placement was possible in 58 patients. So more than half of the patients, you could have done it, or maybe you did, solving or treating the patient with early implant placement. But you know, Professor Cosyn, there it starts the debate, because Ronnie Young asked me to put that slide in, because he would even say no. When I would look to 100 patients, he could even do it in 90. So you see, there is a little debate, still ongoing, but common sense is probably that it's quite often. But you know, patients, they don't really care about clinical views. They more care about comfort, pain, the amount of treatment time, how many times they have to come in your prior practice, and probably also about the aesthetics. So how do patients perceive early implant placement? And for that, also with Professor Jan Cosyn and his group, and our group from Zurich, we did a multi-center study. And one part of the study was to evaluate patient satisfaction for early implant placement. So patient had to rate if they are very happy or very unhappy. And they rated at crown delivery, no, very much happy with that protocol. So happy patient, easy life, but how do we feel about it? Because actually we are the person who has to perform a certain timing protocol. And for that, in the same study, they also asked the clinicians about the difficulty when they did the surgical intervention, and they had to write between very easy to very difficult. And they rated it this way. So tooth extraction, still not very difficult, but it just gets a bit easier, more stressful. So if you would measure the cortisol, it would probably go up. And it peaks at implant placement, probably because you see, maybe it's difficult, maybe you have to do a GBR, so it gets easier for them, apparently. And then they can relax more when they close the flap. So in general, you can say early is somewhere moderate, difficult. Not very easy, but also not very difficult, according to those who answered the questionnaire. And that brings me to a case, just to illustrate that further about early implant placement. And by the way, that's Emma. Emma is young, and she loves to do rollerblading. And at a very sunny day, she went out with her friends, but she couldn't see that on the street. Obstacle, stones, she felt, and the story begins. She had to do a root canal treatment, and then it was okay for a while. She came later back to our clinic, older, but with a broken tooth. Tooth was fractured, causing afterwards a fistula, and when we can already assume that there is not much bone left on the buccal side. And she also wishes to have few surgical interventions and a short treatment time. And she says that with a really bright smile, high smile line. So it's not an easy case when you see, okay, not much bone there. The shape of the tooth is also kind of tricky. High smile line. So everything together, the clinical situation with patient expectation, brought us to plan that case with the early implant protocol. So we continued with tooth extraction, and we allowed a spontaneous healing for 8 weeks. And already after 8 weeks, you see soft tissue matured nicely. But what you also see, that the buccal volume, the contour reduced during that course of 8 weeks. So we continued with flap elevation, and here you see huge buccal bone defect, goes really deep, and probably caused by the extraction, infection, and the bone resorption. And when you see it on the buccal side, you see it's a major buccal bone dehiscence, 2 walls still. So we continued, and we placed the implant with a good primary stability. And you might think, okay, maybe we could have even done primary bone augmentation, but we continued this way. And to compensate for the bone, for the volume, I continued with the L-shaped technique. So the L-shape goes like the long part goes over the implant threads, and then the little part of the L goes over the top of the implant, and not necessarily to gain there more bone, no, to enhance the soft tissue profile. I adapted the membrane, and I closed the flap. And from there on, it's everything about keeping that volume you just have built up. But what can you expect from that? And that's another study, the same study I presented just before, same group, and they were also looking at that. They were looking what happens with the buccal contour, so between tooth extraction and 5 months later. And for that, they took digital impressions from both time points, And the STL data sets, they were superimposing it, and they were measuring the changes. And they could see, just for the early implant placement, that there is a loss of about 1 millimeter. So this is what we can expect. Also, in my case, 5 months later, you see a bit of a volume loss. I continued with the abutment connection, and I knew with that little roll lab, I can enhance a bit of the volume again. Then the implant provisional phase started, so after 2 or 3 sessions, creating an ideal emergence profile, I was ready to do the implant impression again. So I individualized the just created emergence profile, gave it to the dental technician, and after several try-in sessions, that was the result, the implant crown. I delivered it to the patient. And that was the situation at crown delivery. And you want to keep this situation for a lifetime, hopefully. But what will happen? And what can we expect? And that prompted us to this study, to this retrospective study. And we invited back 14 patients. They all got an implant, and the implant also got GBR with an L shape. And then at the follow-up meeting, we were assessing the aesthetic outcomes. So we were looking at the soft tissue, as well as prosthodontists, also about the crown. And on the one side, you see the soft tissue parameters, and the pink aesthetic score is quite high. So 10 is the best you can get. A 7 is pretty good when you consider that some patients had that implant already 14 years in their mouth. But also the white, the crown, we were rating it really well, which also means that apparently we have very good dental technicians in our clinic. What we also did is the volumetric measurement again, so we were looking at the margin and we were measuring what happened during that course of 14 years. And 0.4 you don't really see, so you can say it pretty much remained stable volume, or the buccal contour. And we also asked the patient, how happy are you now? Or are you still happy? Yes, they are very much happy still. So, to take home, early implant placement results in high patient satisfaction. Early implant placement is considered moderately difficult at all stages of the surgery. It is associated with buccal contour changes. And yes, that changes remain pretty much stable over the time. With that, thank you very much.
Thank you, Anina, for a brilliant presentation, to be so clean and so clear, to bringing up this topic, which sometimes is not that easy. Thank you so much for your presentation. So I just want to remind you that we have an app. You can go to that app and ask the questions to our speakers. So let me introduce our next speaker. Our next speaker comes from Switzerland, but he's Spanish. He was trained at Tufts University as a periodontist. He is American board certified in periodontology. He is also collaborating with Complutense University. He's part of the team of Professor Mariano Sanz. And he was also an ITI scholar at Zurich University under the umbrella of Christopher Amerly and Ronnie Jung. And today, he's going to focus in the delayed implant placement. Ignacio, thank you so much for being here.
Thank you very much, Helena. Let me just get the laser here. Good morning, dear colleagues. It's an honor and a pleasure to be standing here in front of you and to share the session with friends and mentors. My task today is to be discussing with you about the reach preservation strategies and to shed light a little bit on what is it that this can do for your patients. And I just wanted to start by reviewing a little bit of what has happened in the last 2 decades with reach preservation, and particularly with alveolar socket healing, because the knowledge has certainly evolved, and the techniques that we use to understand what happens after tooth extraction have certainly evolved. If we look at what we did 15, 20 years ago, we were looking at periapical x-rays, we were looking at histological cuts, and we were making inferences, taking 40-micron slides and taking clinical decisions based on this information that we gather, which was a very small part of the socket. We couldn't understand what happened three-dimensionally. And as time evolved, we started to use more three-dimensional data. That was the introduction of STL files, the merge of STL files and DICOM files. And we contributed also together with a group of young Cosyn to better understand the interplay between soft and hard tissue by superimposing DICOM files and STL files. And this allowed us to understand not only what happens 3D around the tooth after we extract it, but to better understand what is the interplay between the soft and the hard tissue. And I tell you that this has changed in a way the way we approach patients when we extract a tooth. So I think Professor Sanz already alluded to this very clearly, but if we look at some of the things that we discussed in the EFP workshop, in the 15th EFP workshop, this is the review from Professor Cosyn, we actually had to state that as fancy as immediate implant is and as good as it is for our patients, it has some limitations. And one of the biggest limitations is that the risk of early implant failure is higher. So when we do immediate implants, we have higher risk, a little bit of a higher risk. It's anywhere between 2 to 5% higher risk of early implant failure. And then I added, and this is me, this is not the paper, saying that obviously there is a greater risk for implant malposition. This is particularly if you go by freehand. If you use a guide, then you will not have this problem. But also I have to tell you there is a greater technical complexity, and this is particularly if you do an immediate loading procedure. You have to control for the occlusion, you have to have the implant having enough primary stability, and the procedure becomes more complex. But as Professor Sanz also stated, we have, after 2 decades of evolution of this technique, understood that there is a series of parameters that we can control to get better results when we perform immediate implant placement. And that is basically filling the gap. That is, as much as we can perform a flapless procedure, we don't want to touch this fragile tissue. The moment you open a flap, you will lose the papilla. We want to use, particularly in the anterior region, canine to canine, a soft tissue graft if obviously the patient has aesthetic demands. And as much as we can, we want to put a provisional restoration, or we perform a healing abutment that holds and that supports the soft tissue. And I have to tell you, this is not me saying. Also, we have saying in the presentation of Professor Sanz that this has an impact clinically. And this is anywhere between 0.5 to 1 millimeter of preservation of tissue. And I'm going to just raise your attention to this number. This is almost a millimeter of putting or not putting a provisional restoration, or putting or not putting an abutment that holds the soft tissue. And this has a clinical impact. So my presentation today, I'm going to divide it in 3 parts. I'll discuss a little bit about the scientific evidence, then I'll move into the indications, and then I'll tell you a little bit how do I perform these reach preservation strategies. So if we start with the scientific evidence, I wanted to share with you just a classic case. This is a tooth that has root resorption that unfortunately we have to extract, and this is the type of procedure that we're going to perform for this patient. That is just a blood clot, and that is called unassisted healing, which means we don't do anything, we wait. And if we wait, you know what's going to happen. The meta-analysis from TAN tells us that 2 to 4 millimeters, this is the range of hard tissue collapse and soft tissue collapse horizontally, and vertically we have about 1 to 2 millimeters. But if taking a case that is very similar, we do something different. So here, once again, a tooth that is hopeless with recurrent periapical infection and no buccal plate. And what I'm going to do for this patient is I'm going to do some socket filling. I'm going to put a biomaterial inside the socket. I'm going to put a membrane on the buccal aspect, and I'm going to seal the wound with a free gingival graft. And this is what I see. This is 6 months into it. So if we look at the review from Avila, in that reviews basically what happens after ridge preservation strategies, it tells us that these numbers go about 1 to 2 millimeters of horizontal collapse and about 1 millimeter of vertical collapse. So this is more or less reducing to a half of what happens if we don't do anything. But let me tell you the story that very often we don't discuss, and that is what happens afterwards for these patients. Because this is something that we don't discuss. What is the next steps for these patients? Well, let me tell you the story of the patient from above. You see, this is the unassisted healing, so-called early implant placement also. So I raise the flap, and then I obviously have a bone dehiscent, so I have to place my implant. And then there is a significant part of the titanium that is exposed. I have to perform a bone augmentation procedure. And then 6 months after, I still have some soft tissue collapse. Now maybe I have to think about a connective tissue graft. You know, this is going to get anywhere between 9 to 12 months of treatment. But if at the time of implant placement, I perform a ridge preservation procedure, I'm coming back anywhere 4 to 6 months, depending on the type of defect, and I'm performing a minimally invasive surgery. That is, I'm just using the crestal tissue to further bulk the buccal aspect, and I'm placing an implant that is placed flapless, and then afterwards, I'm using, again, a customized healing abutment to support the soft tissue. So when the case above has very complex treatments that take a long time, I'm using very simple interventions with very low morbidity for my patients and having yet very good results clinically. So what the interesting thing about the Avila review that is not very frequently discussed is that there are 2 types of interventions that we perform. And one is ridge preservation. If you want to preserve something, you have to have something to preserve it. And the other concept is ridge reconstruction, which ridge reconstruction means that there is no buccal plate. And if there is no buccal plate, we have to try to rebuild the ridge. And I have to tell you, when Gustavo Avila looked at these studies, 13 of the studies were dealing with ridge preservation, and 5 of the studies in this review were dealing with ridge reconstruction. So the majority of the evidence that we have is based on the images on the left, which are the ridge preservation. And as Mariano stated before, these are patients that are very likely to benefit from immediate implant placements because of the advantages of implant placement, less surgery, shorter treatment time, and the possibility of placing an immediate restoration. So most of the patients that I'm going to be showing you today are these type of patients that actually will, if we don't do anything, will lose a substantial amount of tissue, and they will benefit from these ridge preservation strategies. We also contributed to the literature in my time at Yonsei University with my Korean friends. And basically what we looked is over 650 patients and over 800 implants. And we looked basically at what would happen comparing patients that had ridge preservation and patients that didn't have ridge preservation. And we looked at how likely it is that we perform complex advanced procedures. Those are basically vertical bone augmentation and lateral bone augmentation. And what we found is that whether we looked at posterior teeth or anterior teeth, the likelihood of performing advanced bone augmentation procedures was very drastically reduced. This is 15 to 20% less likely when you perform a ridge preservation. I think this is positive. I want to perform simpler treatments for my patients that have less morbidity. So this is helpful for patients, I believe. The other concept that I think we have to discuss is the concept of socket filling. That is, you're going to fill the socket with biomaterial, and socket sealing. That is, you're going to use a connective tissue graft, or you're going to use a free gingival graft, you're going to use a membrane, you're going to use a pontic to seal the wound. And I have to tell you that today we have evidence that tells us, and this is the study from Martins that performed a meta-regression analysis comparing techniques that were exposed, such as an assisted healing, such as, for example, open healing without a barrier, and compare it to, for example, flap advancement or open healing with a barrier, sealing the socket. Now, we're not going to perform a flap advancement that would displace the mucogingival junction. This is not something contemporary that we would do today, but it compares socket sealing without socket sealing. And the results are very clearly favorable of socket sealing. So socket sealing apparently renders better results in terms of preservation of particularly the hard tissue. So now moving into the indications of when should we be performing ridge preservation and when should we be performing immediate implant placement, I think what we should be doing is putting or confronting the benefits of immediate implant placement and confronting these benefits with the risks of immediate implant placement, because this is at least what I have in mind, because implant placement for the patients, we can discuss about the clinical results, but for the patients, it's a superior treatment. It's less surgeries, it's faster, and most of the times they can leave the office with a provisional tooth. The risks are that, as we said, we may have higher risk of implant failure, but we also have to tell you there is a risk of not placing the immediate implant. Because what we see is that when you don't do anything, the tissues collapse. And when the tissues collapse, the effort that you have to put to get these tissues back is substantial in terms of time, in terms of surgical morbidity. As we saw in the previous presentation, you have to perform very advanced bone augmentation and soft tissue augmentation techniques to recover the soft tissue and the hard tissue that you lost. So what about if at the beginning, we try to not lose what we have, as opposed to losing it and playing the catch-up game later to recover it. So those are things that I think we have to keep in mind. But if I show you this patient that has repeated abscesses in the central incisor, this is a patient of long-standing trauma anywhere in the central and also in posterior sides. The tooth is fractured, has caries. So now we take a CBCT, and this is the placement. You can see that I can place the implant, I can anchor the implant, but I have an important buccal dehiscence. So this is the image in the video. So you see there is a wide U-shaped dehiscence, and I have a lot of unsupported tissue. To me, I would take too many risks here. Placing an immediate implant, I'm more comfortable performing a ridge preservation procedure. Let's take a look at this other case. You see that I could anchor the implant, but already in the apical aspect, I have a dehiscence. And if I show you the three-dimensional image, you would see that when I place the implant, most of the implant is completely unsupported by bone. Am I going to place an immediate implant here? I don't think so. I have a very large defect. I will have a lot of titanium exposed. I'm not comfortable with that. But here, different case scenario, also hopeless tooth. I can place the implant very comfortably. You see, I can anchor the implant. I will have certainly enough primary stability. I'll be able to put a provisional restoration. But if we take a minute, if we observe this, how far am I from the adjacent insertion, for example, of the central? Take a look at here. When you see here, I remove here, this is the shoulder of the implant. Take a look at the apex of the lateral. This implant is really, really high up. I don't want to do this. So I'm not going to perform an immediate implant here. If this position of the implant is incorrect, this is too deep, I will perform a ridge preservation procedure and come back later. But we not always have to perform 3D images. This is another case. You see palatal dehiscence, you see buccal dehiscence. So also, in these type of cases, I feel more comfortable performing a ridge preservation technique. How about the soft tissue? Well, the soft tissue is also a problem. Take a look at this patient with tooth resorption. Here I'm checking with the caries probe, and with the caries probe, I'm at the apex. So obviously, if I'm at the apex, there is no bone on the buccal aspect. This is not a case, in my opinion, for an immediate implant placement. Look at the smile of this patient. I'm not going to be taking chances. Obviously, also ridge preservation will be more prudent and will be indicated in this case. So let's look in these last 5 minutes about what is the clinical application, how we can perform these ridge preservation procedures. And I wanted to start with this patient. This is also a patient with long-standing trauma, and she has had already 2 retreatment procedures, and she's still having repeated abscesses on this central incisor. And when I take a CBCT, you can see, once again, substantial amount of bone loss. You can see that there is a large apical defect here. And obviously, you could ask me, can you stabilize this implant? Can you go and anchor this implant here? Maybe. Do I want to do that? Do I want to complicate my life to such extent? Absolutely not. Absolutely not. I don't want to take these risks. So in this particular case, I will remove the other crown, and then what I will do is I will just perform an apical incision. I will access this by this apical incision, the defect. I will clean it thoroughly, and then this is the socket filling. In this particular case, I'm using a connective tissue graft. There is a barrier also on the buccal aspect, and then I'm just using a simple collagen matrix to better stabilize the blood clot in the crestal aspect. And then from here, I'm once again sealing the wound with the pontic that I created, or that I stabilized on the adjacent teeth. So this pontic is stabilizing the tissue. We're taking the concepts of immediate implant placement and taking them to ridge preservation to try to simplify the treatments for our patients. So this is the 3-month evaluation. I perform a BOPT preparation on the adjacent central incisor. And then at this point, I can take a CBCT, and the situation has changed dramatically. With a very simple procedure, I can now perform an implant relatively comfortably, no extensive bone augmentation procedure. And once again, if I show you what the changes are before and after the tissue contours, before the ridge preservation and after the ridge preservation, this is about 0.6, 0.7 millimeters. So what we were able to do is, by supporting the soft tissue and grafting, we were able to better stabilize the soft tissue. And now I can perform a flapless procedure. I don't have to raise a flap. I don't have to perform a bone augmentation procedure. This is a fairly simple procedure. I perform a connective tissue graft on this side. That's why you see the sutures, but otherwise, this would have been a simple procedure. So here's the follow-up 2 years after, with stable results, and once again transforming a case that could have been complex with extensive bone augmentation to something that I would say is relatively simple. Let's look at this other case, and you see this patient. You can see that she has 2 full coverage crown on position 1.1 and 1.2, and this is the situation after 2 apical surgeries. There is a through-and-through defect, and obviously it's the time after 2 apical surgeries of performing the extraction. Patient has repeated infections, has pain. So the case, or the patient, the situation is further made complex by the fact that she really disclosed the region of this lateral. And I have to tell you that there is no way I'm going to place an immediate implant here, and there is no way I'm extracting this tooth and leaving this tooth and this tissue unsupported. When I extract the tooth, I want to support the tissues, because I know if I support the tissues, I'm going to have less chances of these tissues collapsing. Is the concept of not letting everything collapse and then play the catch-up game to recuperate it, but trying to stabilize it from the beginning to lose less than what I would do if I wouldn't do anything. So obviously, it's of importance to perform a careful extraction. You can use this type of devices. If you have good dentin, you can anchor the tooth, you can anchor these posts, and then when you extract the tooth, obviously the soft tissue is preserved, and then this can make the procedure relatively simpler. You can see that this patient had a large apical cyst. And then after this, I'm going to perform what I explained you before. I will perform the socket filling with the biomaterial. In this particular case, due to the high aesthetic demand, I also perform a connective tissue graft. But I think what is important in this case is that I use this type of simple provisional restoration to better support the soft tissue. And by supporting the soft tissues, I'm going to try to minimize the loss of tissue that I'm going to have. And this is basically the 1-week follow-up. Tissues are a bit inflamed. You can see this, the apical incision here, where I tunnel the membrane and the biomaterial. And this is the situation 6 months. There was a large defect, so I waited 6 months. So we still lost something, but the situation is rather favorable to go ahead and now perform a minimally invasive surgery. You can still perform a graft here, but you know the case and the situation is no dramatic. You can see that I'm placing an implant without any need of further bone augmentation. So this is, in a way, what you would call in the office a straightforward case if you would see it from the get-go. Let me just show you to finish this case, and this is, you may ask, do you always have to prepare the adjacent tooth? No, you can use other strategies. This is a case that I showed you before. You remember that it had a large defect, and then basically what I do here is just, again, an apical incision, clean the defect, and then when I clean the defect, you can see, once again, the defect here, membrane, biomaterial, and after using the biomaterial, compacting gently the biomaterial, I think it's important, a collagen plug, and after the collagen plug, this is a simple Maryland bridge that once again supports the soft tissue, a provisional Maryland bridge. And I can tell you, this is 6 months after, barely any tissue loss. I can place the implant in a comfortable way, and when I looked at the superimposition, mainly any loss of tissues. And we looked in the office, 10 patients at the 6-month follow-up, and what I can tell you is that none of these patients had the need of a dehiscence, of extensive bone augmentation. Only 2 had fenestrations when I placed the implant virtually, and the loss of tissue was really minimal. So the conclusion is that when immediate implant is not possible, ridge preservation can attenuate the changes. Ridge reconstruction techniques will simplify and reduce the need of guided bone augmentation procedures, and sealing socket strategies are definitely of advantage for our patients. So with that, I thank you for your attention.
Thank you so much, Ignacio, for your brilliant presentation. And I would like to know what happened to Jan Cosyn's patient. Would you like to show us what did you do in that situation?
Absolutely.
Thank you.
Well, I can imagine that you must have thought, Jan is coming, he will show an immediate case. But this is not an immediate case, of course. And Ignacio couldn't have made it easier for me, because he showed virtually exactly the same case a few minutes ago. We didn't consider here apical surgery, because that was one of the questions coming to us, because the tooth was very mobile also. So we had to go for tooth replacement. And of course, we could anchor an implant, even an immediate implant here. But what about the prosthetic position? For sure, we will end up in the failure zone with that implant, and it will be an aesthetic disaster. So immediate implant placement, really, it's not the way to go here. And to some degree, it also applies to early implant placement, because 4 to 8 weeks later, there will be minimal bone formation. So the implant placement itself will not be much easier then, and we could have the same problems in the end. So what we did is a minimally invasive approach. And if I go back to you see there at the cervical aspect that it is in fact a fenestration. It's not a dehiscence. There is a little piece of bone there, which is quite favorable for a alveolar ridge preservation procedure. But of course, we have a huge apical pathology, so we need a barrier, which can be a non-supportive barrier here because of that tiny piece of bone. And we don't elevate the flap, because we don't want to compromise wound stability. In this particular case, I always use a combination of autogenous bone chips and DBBM, 1-to-1 ratio, because I want to have osteoinductive and osteogenetic properties, not only the conductive properties. And then we go on, we just fill it by condensing it slowly but surely in a buccal positioning, in a buccal dimension. And then we fill it up to the level of the palatal bone crest. We fold the collagen membrane, and then I close it off with a collagen matrix usually. We wait for 5 to 6 months of healing, and this is then the corresponding CBCT slice, which shows a beautiful healing, good maturation, and a good situation to continue with implant placement using a surgical guide. And of course, as always, we have some collapse, as has been shown by Ignacio, but we have a good bone volume to place the implant in a perfect prosthetic position. We make the impression, and of course, we continue by augmenting the soft tissues. This is a free gingival graft that needs to be epithelialized, de-epithelialized. You can do that intra or extra-orally. And then you make sure that you reverse this connective tissue in order not to have aesthetic complications in the end if you have some remnants of epithelium there. Okay, we place it at the time of implant placement under the buccal flap. We suture it in a certain way, and we combine it, at least I try to combine it as much as possible with an immediate restoration procedure. And I couldn't agree more with Ignacio. We need to support the soft tissues from day 0. So this is how the patient leaves the office, and this is then 3 months later, where we have a perfect integration good positioning of the implant, and then the patient can be sent back to the referring dentist for the permanent restoration. Helena.
Very good. Thank you so much
Okay.
for your beautiful presentations. And we have a lot of questions, which is quite impressive. But some of them focus on the same thing, bone graft material. And the audience would like to know, and I'll ask the four of you, okay, which bone graft material would you use? I can start with Ignacio for alveolar ridge reconstruction / preservation. Which biomaterial is your golden standard?
I can answer the question quickly by two means. If we look at the scientific evidence, Gustavo Avila really looked into this very deeply, and if we look at the evidence, there is no superiority of any biomaterial in terms of preservation of the ridge, whether you use an allograft or a xenograft, which are the two options that you have. If we look at histological studies, basically what you see with the allografts is higher percentage of new bone, higher turnover, a little bit less of dimensional stability. And what you see with the xenografts is a little bit more of residual bone graft and less new bone formation. You also tend to see clinically a little bit more of this popcorn effect with the xenograft as compared to the allograft. So I use both. If I'm not going to be placing an implant and it's a pontic site, for sure it's going to be a xenograft. And some of the cases that you've shown here, they were done with an allograft mostly, but I also use xenografts, and I've used them in the past with very good results.
Jan, would you like to comment on this?
I'm on the same page there, but depending on the extent of the pathology, we tend to include more and more autogenous bone.
Okay.
Because if the pathology is really huge, I want to have bone formation from within the graft.
Okay.
So you induce it a little bit more, and but this is just clinical feeling. When we go to the reopening, the re-entry, I think the quality of the bone, having that autogenous bone included, is most often much better when you compare it to a xenograft.
You would do it like a 50-50?
Yeah.
Like half-half?
Yeah.
Okay. Mariano, for filling the gap, you place an immediate implant and you have a gap. Which biomaterial would you select for that?
Well, I try to bridge both questions. One thing is what we can say evidence-based.
Exactly.
Another thing is what we can say in our clinical experience. And another thing is what we can foresee for the future. So in terms of evidence-based, I think the answer is very clear. Most of the evidence we have is with xenografts. Mostly when we have a high porous structure that allows the ingression of bone and the stability of the bone inside the xenograft, but the xenograft will not disappear, will stay there, provide you with a good volume and stability, but in a way, it's something that is disturbing because it's there all the time. So in my clinical experience, I always have tried to be evidence-based, so most of my experience is with xenograft, but I really want some induction, so I would absolutely favor what Jan Cosyn was stated of adding some autogenous bone. But is this the future? Is the future using bovine bone and autogenous bone from the patient? Definitely not. So the future has to be synthetic, and the future has to be inductive. So there is a lot of research going on composite biomaterials, with polymers, calcium phosphates, with new inductive biologicals, and I'm sure these things take time, but the future, at least in my mind, is not taking autogenous bone from the patient and using xenogenic grafts. What I use today, exactly, xenografts and autogenous bone, because this is what the evidence we have.
Okay. Anina, early implant placement.
Yes.
Which bone graft would you select?
I mean, I can just add on what was already said. So I go with xenografts also. And so I was showing actually a case, and there, sort of facilitate also. I also use kind of a soft type block. I trim it in a shape of an L, which, you know, you do things in the clinic probably which helps you to facilitate treatments. For me, that is one thing. But when we come to materials itself, it's xenograft. What comes in the future? I don't know, but probably I will see it.
And does the size of the particles matter when we're doing these type of procedures? For example, both of you showed a very similar case. You did more or less the same approach, different way of doing the socket or ridge reconstruction. You used a mixture. You used a xenograft, but you use a connective tissue and you use a collagen membrane.
Yeah, we come back later with the connective tissue graft.
Oh, you go later, okay.
Yeah.
But what size of particles are you using? Small or large?
I'm using, I think it's a standard size, but I think the particles, I wouldn't use any large particles like you could use, for example, in a sinus. But I think what is crucial is to really compact the biomaterial so that it is stable. Because when you just gently put the biomaterial and the biomaterial is flying on the blood clot, there is no stability. So what I do is I just use the back part of a hand mirror or anything that can compact the biomaterial, and then I rinse with a syringe. And I want to make sure that when I rinse with saline, there is no biomaterial moving or leaving the socket. And this is what I define as stable. And to me, this is more important than whether the sizes are 0.02 or I take what the industry gives me, which is companies that have obviously well done research. So.
Okay. There's a question here that is, does delayed implant placement always go hand in hand with alveolar ridge preservation? Who wants to answer? Jan?
Well, historically, delayed implant placement is without alveolar ridge preservation. And then later on, the term was introduced. So in my view, alveolar ridge preservation is kind of combined with late implant placement. You postpone implant placement usually beyond 4 months, which is then late. Because you need some healing of that bone, that healing compartment to proceed with implant placement. You want to have a stable environment, and that takes some time.
Yeah, and also if we are using either alone or in combination xenografts, you need the time to allow for some bone to get into that porous structure, because otherwise you will place your implant through a xenograft. And I think this is something that you wouldn't do.
There's probably a misconception a bit. A lot of people tend to believe that a xenograft speeds up the healing, but in fact it slows down the healing.
Yeah.
It takes more time to have a mature environment.
Okay.
So 4 months is usually not enough to put the implant in.
Wait for 6 months minimum.
I do 5, but at
okay.
least a little bit longer than 4.
So another question that I have here is for Mariano. Do you always take a CBCT before an immediate procedure, especially in the aesthetic area? Thank you for your answer.
Well, I think this is a very good question. And I recall a study that we did. The first author is Oscar Gonzalez, that we measured what is the sensitivity of CBCT if we take it with a tooth in place. And the sensitivity is basically 0.8 millimeters. And we know from the literature that most of the anterior maxilla buccal bone thickness is less than 1 millimeter. So that means that if you take the CBCT with a tooth in place before the extraction, any buccal bone that is less than 1 millimeter, you will not be able to identify it with the CBCT. So then the question is, should you do the CBCT before or after the extraction? And the problem is that most of the time the CBCT is also a guidance for your decision to extract. So you don't want to do the CBCT after the extraction. So these are some of the limitations that we have with the current diagnostic technologies. Of course, we understand that if we don't see the buccal bone it means that it's either non-existent or extremely thin. Yeah. So, but I don't think we can be extremely accurate because the sensitivity is not there.
Exactly. Thank you so much for your answer. Anina, in early implant placement, does the procedure adversely affect bone healing? Additionally, how do you recommend timelines for early implant placement if they differ between maxilla and mandible?
Okay, I see there are two questions.
There are two questions, yes.
Okay, first question. I don't think that when you place the implant with the early protocol, it somehow interferes or it differs in terms of bone healing.
Exactly.
Yeah. But yes, I mean, that's one of the reasons why you probably go for early implantation is that you need to build bone there because there is no bone. And from there on, I would say it's just, as with all the guided bone regeneration procedures, it behaves in the same way, and it doesn't depend on what timing I chose at that time.
Okay. And would you difference between maxilla and mandible in the timing of waiting? Would you go for 4 to 6 weeks, or you? Okay.
No, because there's the anatomy and there's a defect, and it's the same if you go in the upper or in the lower. You get what you get.
So we have time just for one last question for Ignacio regarding the prosthodontic part. Okay, if you don't have an abutment tooth next to the area that you did the extraction and the socket preservation, would you provisionalize with a removable? What would be how would you do the provisionalization?
I mean, the clinical reality is that sometimes you have to provisionalize with a removable, and it's not the end of the world, you know. So, but what the concept that I was trying to bring is that if you can stabilize the soft tissue with a pontic, and that means that you can use it maybe with the Maryland bridge, or because you have to change the adjacent crown, then obviously this has a lot of advantages because you can support the tissue. And what we see is that in the transmucosal region, which is the critical part for the aesthetic, you really lose less volume, and then the subsequent procedures are simpler. If you cannot do that because for X reasons you cannot do this, then you perform a removable, and then you play the game that we have been playing for 20 years successfully. So it's not a major problem. I think the one thing that I want to make, maybe to state that it's important, is that we've been discussing a lot about single tooth extraction.
Exactly.
And what we discuss about single tooth extraction doesn't necessarily apply by adjacent teeth extraction, where you lose a lot more, and is a lot more to recover. So the studies that I presented you were single tooth extraction, where you have the adjacent teeth, where the defect is a very well contained defect with a mesial wall, with a it's a very, very favorable situation for healing. But the moment you have to, for example, extract 2 adjacent teeth in the anterior aesthetic zone, then these type of preservations, particularly in the soft tissue, in between the 2 teeth, you will lose a lot more. And no matter how many pontics you perform, you will lose the soft tissue.
Thank you so much. I have just one last question for Mariano. It's a question that just came in, and I think it's a very important one. Professor Mariano, when is contraindicated to perform immediate implant placement? It's not an easy question.
Well, I think the answer is very straightforward because I think it was answered in the presentation by Ignacio. I think if we don't have the buccal bone, and if we have quite a major destruction of the buccal bone, I don't think the immediate implant is indicated. Maybe done successfully, but this added complexity perhaps is not worthy if you want a real predictability of the aesthetic outcome. So definitely I would concur with Ignacio's way in the terms that the critical aspect in the decision is how much buccal bone I have lost.
Yeah, perfect. Thank you so much. What a way to finish up this session. Dear colleagues, dear friends, thank you for being here till the end. We now have our coffee break, and we'll be back at 11:15. Thank you so much.
Thank you.
Very good.